Good afternoon, everyone. I am Dr. Arun Jindal, Junior Resident in Department of Psychiatry. Today, I will be discussing a very important drug that is lithium, a mood stabilizer. In this seminar, I will be covering some historical facts about the lithium, mechanism of action of lithium, pharmacokinetics, therapeutic indication of lithium, serum lithium concentration required for various disorders, adverse effect of lithium, lithium toxicity, drug interactions, dosage and clinical guidelines, lithium preparation available in India, and the use of lithium in special population. Firstly, some historical facts. In ancient times, people used mineral springs with lithium for healing because they believe that these waters can cure various health problems, including mental health issues. The elemental lithium was discovered by Swedish chemist, that is Johann August, in 1817. In mid-19th century, lithium salts were used to treat various physical ailments, that is gout and kidney stones, because they believe that lithium has the ability to dissolve uric acid crystals. In 1949, the Australian psychiatrist, that is John Cade, introduced lithium in a modern psychiatry. As per him, mania was caused by toxic substance in the body. He injected guinea pigs with urine extracts from the mania patients, which made them extremely ill. After that, he injected the lithium carbonate to the urine extract that prevents the toxicity in the animals and calm the animals without sedating them. In 1960, Morgan Scow conducted various clinical trials that proved the lithium efficacy in bipolar disorder and also set the safe guidelines to be used in bipolar disorder, and this will lead to the global acceptance of the lithium. In 1970, the US FDA approved the lithium carbonate for the treatment of bipolar disorder. After that, the lithium was used as a first-line treatment for the bipolar disorder. Mechanism of action of the lithium. In the neurotransmitter bind to the receptor on the neurons that will activate phospholipase C, and that will convert the membrane phospholipids, that is phosphatidyl inositol biphosphate, into inositol triphosphate and diacylglycerol. And these both molecules, that is IP3 and DAG, will release the intracellular calcium from the endoplasmic reticulum that will affect neuronal excitability and neurotransmitter release. In bipolar disorder, these transaction pathways got dysregulated, and that will lead to the abnormal neuronal excitability and neurotransmitter imbalances. Lithium appears to decrease the inositol levels, that will decrease the concentration of the IP3 at the DAG, and that will reduce the excessive signaling and helping to stabilize the mood. Lithium also inhibits an enzyme, that is glycogen synthase kinase 3 beta. This enzyme helps in various processing like neuronal cell survival, neuronal cell differentiation, and synaptic plasticity. By modulating this enzyme, it can enhance neurogenesis and also has a neuroprotective role and can influence the synaptic plasticity. Lithium is seen to increase the various neurotrophic factors, that is brain-derived neurotrophic factor. This also promotes neuronal growth, survival, and synaptic plasticity. These all effects can lead to mood stabilization and improving the cognitive functions. Therefore, it can be a valuable treatment option for conditions like bipolar disorder and other mood disorders, and can also have a neuroprotective role. Pharmacokinetics of the lithium. Lithium is quickly absorbed with peak serum levels occurring in 1 to 1.5 hours of standard form and 4 to 4.5 for extended release forms. Unlike most drugs, it has no protein binding properties and no metabolites. It is entirely excreted by the kidneys with a very small quantity in sweat and feces. The elimination half-life is 18 to 24 hours, and it is longer in elderly patients because they have compromised kidney functions. Lithium enters and exits the CNS slowly, therefore it can explain the delayed onset of the symptoms in acute overdoses and the persistent effect of the symptoms in chronic intoxication even when the blood levels drops to normal. Therapeutic indications of the lithium. First one is the bipolar disorder, mainly bipolar 1 disorder. It is a FDA approved drug for manic episode, and it can prevent relapse in 80% of the individuals with bipolar 1 disorder. Lithium has a relatively slow onset of action, and it will take about 1 to 3 weeks to exert its antimanic effects, and therefore we have to add benzodiazepine and second generation antipsychotics for the first few weeks to deal with the symptoms. Lithium is less effective for individuals with mixed mania or dysphoric mania, rapid cycling bipolar disorder, comorbid substance abuse, and mood changes, or if related to any other organic condition. Lithium is also used for maintenance of the bipolar disorder. It can reduce the frequency and severity of the episodes and reoccurrence of the mood episodes, mainly in the mania. Lithium is also used in major depressive disorder. Mainly, it is used in treatment-resistant depression, where the antidepressant alone cannot able to cure the illness. Therefore, it is used as an adjunct to antidepressant, and about 50 to 60% of the non-responders improve by lithium. It is also used in schizoaffective disorder and schizophrenia, mainly in the disorder in which the patients have a prominent mood symptoms that can be of bipolar type or depressive type. It is not very effective in the patient in which there is predominant psychotic symptoms. Although antipsychotic is a treatment of choice for person with schizoaffective disorder, but lithium can be used as an augmentation agent. It is also used in aggression. It has anti-aggressive effects. It can be used in a particular patients like in prison inmates and individuals with intellectual disabilities, having behavioral disorders and having self-mutilation characteristics, and the children with conduct disorder. These are some other use of lithium. It can be used in cluster headaches and alcohol use disorder having affective symptoms. It also has a granulocyte stimulating effect, so it can be used in a clozapine induced agranulocytosis or chemotherapy induced agranulocytosis. It has also a neuroprotection role, so it can be used in Alzheimer's disease. It is also used in suicide prevention in the patient like in severe depression. It can be used in post-traumatic stress disorder and in borderline personality disorder. These are the serum lithium concentrations in various disorders. For mania, we have to achieve the target serum concentration of 0.8 to 1 millimole per liter. For maintenance of the bipolar disorder, it should be of 0.6 to 0.8 millimole per liter. And for the unipolar depression, it should be of 0.6 to 0.8 millimole per liter. And toxicity is seen after 1.5 millimole per liter. These are the adverse effects. Firstly, some common side effects of the lithium. In GIT, it can cause nausea, vomiting, and diarrhea. In renal effects, it can cause polyuria, polydipsia, because it can inhibit the effect of antidiuretic hormone on kidneys, and it can also cause potential pharmacological, morphological changes in the renal structure that in long-term use. It can also cause endocrine effects like subclinical hypothyroidism and goiter. In neurology, it can cause memory impairment, slow reaction time, postural tremors, neurotoxicity at higher serum concentration. It can also cause acne, psoriasis exacerbation, and hair loss. It can also cause ECG changes like T-wave flattening and inversion. It can increase appetite and weight gain in many patients. And it can also cause hypercalcemia. And many of these side effects are dose related, and it can be managed by adjusting the dose. This is the lithium toxicity. It is seen after when the lithium level raises from more than 1.5. If the level is 1.5 to 2 milliequivalent per liter, it is under mild to moderate intoxication, in which we can see vomiting, abdominal pain, anorexia, diarrhea, and nausea, and ataxia, coarse tremor, confusion, drowsiness, muscle weakness, and slurred speech. When the level raises to 2 to 2.5 milliequivalent per liter, it can cause persistent nausea and vomiting, muscle twitching, clonic limb movements, seizures, disorientation, and coma. And in CVS, it can cause arrhythmias, conduction abnormalities. More than 2.5 can cause severe lithium toxicity. It can cause generalized convulsions, oliguria, renal failure, and finally death. These are some risk factors that can increase the chances of lithium toxicity. Firstly, the dehydration. Dehydration can be caused by diarrhea, vomiting, excessive sweating, fever, or inadequate fluid intake. In the renal diseases like chronic kidney disease, acute kidney injury, and age-related decline in the renal function. Electrolyte imbalance like hyponatremia due to excessive sweating, poor dietary intake of sodium, or the use of diuretics. In advanced stage, there is the age-related decline in the kidney functions, and multiple drug interactions can be seen. In acute illnesses like gastroenteritis, severe infection, or any condition causing significant fluid loss or renal impairment. Or if there is a rapid dose titration of lithium without appropriate monitoring, including exceeding the recommended dosage. Many drug interaction can also cause the increased lithium levels, mainly by two mechanisms. It can be caused by reducing the renal clearance of the lithium, or can be caused by sodium depletion. Drugs like NSAIDs, non-steroidal anti-inflammatory drugs, can raise lithium toxicity by reducing prostaglandins, that will decrease the kidney blood flow, so it will decrease the renal clearance of the lithium. And diuretics, mainly the thiazides, it can cause lithium toxicity, mainly hydrochlorothiazide and chlorthalidone. Antihypertensives like angiotensin converting enzyme ACE inhibitors, that is lisinopril, enalapril, and ramipril. Angiotensin receptor blockers, that are losartan, valsartan, and telmisartan. And selective serotonin reuptake inhibitors can also increase the risk of serotonin syndrome in combination with the lithium. Antibiotics like tetracyclines and metronidazole can cause renal toxicity that can further cause lithium toxicity. This is the treatment of the lithium toxicity. Firstly, we have to discontinue the lithium immediately. After that, if the patient comes within 1 or 2 hours, we can do the gastric lavage, and we have to send the lithium levels to confirm toxicity. After that, we can use alkaline diuresis, in which we can administer IV normal saline 0.9% NaCl to enhance renal clearance of the lithium, and we have to avoid hypotonic solution like dextrose 5% water, as they can exacerbate hyponatremia. We have to correct the electrolyte imbalances, mainly the sodium levels. Hemodialysis can be used when the lithium levels are more than 3 millimole per liter, and peritoneal dialysis also can be used here. Lithium levels may increase again after initial dialysis due to rebound effect, so multiple sessions should be done. Clinical symptoms may improve slower than serum levels due to slow CNS clearance. Dosage and clinical guidelines. Before prescribing lithium, we have to do renal function test, thyroid function test, and cardiac function test. And we have to also do ECG in patients who have a risk factor for cardiovascular disease. We have to go for a BMI and have to measure weight, because it can cause weight gain also. Typically, we have to start the dose at 400 mg once daily at night. In elderly, we have to use half dosage, that is 200 mg once daily at night. And after that, we have to check the plasma levels of the lithium after 5 to 7 days. And if we are adjusting the dose, again we have to recheck the plasma levels until the desired level is reached. In the presence of the normal kidney functions, the daily dose of 1200 to 1800 can produce antimanic serum concentration of 0.8 to 1.2 milliequivalent per liter. And the dose of 900 to 1200 mg daily can produce maintenance level of 0.6 to 1 milliequivalent per liter. And we have to send the plasma lithium levels after 10 to 14 hours after the last dose. And for monitoring the lithium, we have to check the plasma lithium levels after every 6 months, and glomerular filtration rate after 6 months, and thyroid function test after 6 months. More frequent tests may be required in elderly or having chronic kidney disease. And weight should also be monitored with BMI. These are the lithium preparations available in India. These are lithium carbonate. These are in two forms, that is immediate release tablets in 300 mg and 400 mg, and it should be used 2 or 3 times because it has a shorter half-life. And other one is extended release form, that is 400 mg and 450 mg. It can be used once or twice in a day, and it will also reduce the serum level fluctuation of the lithium. Lithium carbonate capsules can be used that can easily swallow and may provide better patient adherence. Lithium citrate oral solution is also there, that has a concentration of 300 mg per 5 ml and can be used in pediatric population and for patients with swallowing difficulties. Lithium orotate is a form of lithium that is available as a dietary supplement in some regions. Lithium used in special population, used in pregnancy and lactation. Lithium should be avoided in first trimester of the pregnancy because it can cause the absent anomaly of the tricuspid valve. Teratogenic risk of the lithium is higher than the normal population, general population, but it is lower than the valproate and the carbamazepine. Lithium is excreted in breast milk, so nursing mothers should weigh the risk and benefit ratio. Signs of the toxicity in infants include lethargy, cyanosis, abnormal reflexes, and hepatomegaly. In elderly patients, lithium is generally safe and effective for elderly, but requires careful management due to factors like decreased renal function and other medical conditions and increased sensitivity in the elderly. Initial dosages should be lower, dosage adjustment should be less frequent, and more time should be allowed for steady state concentration to be achieved. And these are my references. And thank you.